From today, I'm going to start a new series called Top 5. That means I have discussed the top 5 key features of a disease. And today, my topic of discussion is primary CNS lymphoma because I received a request this afternoon to discuss this. Primary CNS lymphoma, the most important thing that you need to know that this is the most common tumor seen in immunosuppressed CNS tumor seen in immunosuppressed individual. This is the most common CNS tumor seen in HIV positive patients also. So, if you get a CNS tumor in an immunocompromised person, the first thing that you should rule out is primary CNS lymphoma. And on the other side, the most notable risk factor for primary CNS lymphoma are the states of immunosuppression. It includes the AIDS, it includes ataxia, telangiectasia, it includes the condition like Wiskott-Aldrich syndrome or uh, post-transplant. So these all immunosuppressive states can act as a risk factor for the development of primary CNS lymphoma. The second key concept that I would like to tell you about primary CNS lymphoma is that they are extranodal variant of non-Hodgkin lymphoma. I think while reading the about Hodgkin versus non-Hodgkin lymphoma, you have read that non-Hodgkin lymphoma has a tendency to arise from extranodal site. Extranodal sites means that they arise outside of the lymph node, not necessary from the lymph node. For example, H. pylori associated moltoma, which is a extranodal marginal zone non-Hodgkin lymphoma. It's a variant of non-Hodgkin lymphoma. So they arise from the mucus-associated lymphoid tissue of the stomach, not from a lymph node. Similarly, this primary CNS lymphoma is also an example, a classic example of extranodal variant of non-Hodgkin lymphoma. And these non-Hodgkin lymphoma, they are usually of B-cell origin. Mostly, majority of them are B-cell origin. Though some Korean studies have found that some primary CNS lymphoma could be T-cell origin, but I would suggest that you should always think that basically primary CNS lymphomas are of B-cell origin, though there are some exceptions they have found. The third key concept that I would like to mention about primary CNS lymphoma is their presentation. The patients usually are seen in their 40s, 50s, and 60s, and the median age of presentation is 56 years. If the patient is immunosuppressed, they may occur at earlier ages also. And their presentation is with some focal neurological deficits. It could be some headache, could be some seizure, it could be some blurring of the vision, because primary CNS lymphoma primarily involve four sites. They involve the brain, they involve spinal cord, they involve leptomeninges, and they could also involve eye. So some eye manifestations could also be there in the patients of the primary CNS lymphoma. The fourth key concept I would like to mention that their diagnosis. The diagnosis is usually contrast enhanced MRI, the radiological test that is the superior sensitive test for this. But ultimate confirmation, the pathological diagnosis is definitely made by biopsy, the gold standard for the diagnosis. And this biopsy is usually done by stereotactic needle biopsy. Stereotactic needle biopsy is done for many sites, like they're done for lungs, liver, breast, and also for the brain tumors. And the stereotactic needle biopsy, the pathologic diagnosis, the histopathologic diagnosis, is done, which is followed by immunohistochemistry. And immunohistochemistry usually gets certain typical B cell markers. The B cell markers which you would be getting, like they would be positive for CD19, they will be positive for CD20, they will be positive for CD22, they will be positive for CD79A and PAX5. And if primary CNS lymphoma are usually not positive, not commonly positive for CD10, if you get a brain tumor which is looking like primary CNS lymphoma and they are positive for CD10, please rule out that there may be a DLBCL which is coming as a metastasis to the brain, because that is more a feature of peripheral diffuse large B-cell lymphoma. And at this point, I would also like to tell you that the most common histopathological subtype of primary CNS lymphoma is DLBCL, diffuse large B-cell lymphoma, which is a type of non-Hodgkin lymphoma you have already read. The fifth key concept about the primary CNS lymphoma, that they are a very highly aggressive variant of non-Hodgkin lymphoma. And if you compare a DLBCL arising from the rest of the body and DLBCL arising from the brain, this primary CNS lymphoma, their prognosis is poorer compared to the DLBCL arising from the peripheral sites. So they are a very highly aggressive variant of often poorly respond to the chemotherapy. And at this point, I would like to mention on the key concept that if you want to do a biopsy, please don't give steroid before doing the biopsy, because then the steroid might causes shrinkage in the size of the tumors and you not get a proper biopsy picture. Diagnosis may not be possible. So if you want to make a stereotactic biopsy, if you want to go for a stereotactic biopsy, it should not be followed by giving steroid. This is another key concept. And if you do the biopsy, the key features which we can get areas of geographic necrosis. We can get the tumors, actually they are seen in the periventricular location, and they are usually show some kind of angiocentricity. That means the tumor cells are seen centering around the blood vessels, which is called angiocentric pattern. This could be seen in this thing. And location wise, the most common site they will see frontal lobe 15%, and 10% cases they could be seen in the periventricular location, also like sites like basal ganglia. So all in all, and obviously the diagnosis would be, the confirmation of the diagnosis is done by the histopathologic biopsy followed by the immunohistochemistry, which I already mentioned. So in a nutshell, what we discussed about the primary CNS lymphoma, that this is the most common CNS neoplasm seen in immunosuppressed individuals. And on the other side, immunosuppression is the most notable risk factor for primary CNS lymphoma. They are basically an example of extranodal variant of non-Hodgkin lymphoma. That means non-Hodgkin lymphoma that are arising outside of the lymph node. They typically arises from the four sites. That is from the brain, that is from the spinal cord, that is from the leptomeninges, and that is from the eye. And histopathologically, the most common variant which we see is DLBCL, diffuse large B cell lymphoma, DLBCL. This is the most common histopathological variant which you see. And another thing that you need to know, that it has been found that they show an association with Epstein-Barr virus, this DLBCL, and not DLBCL, this primary CNS lymphoma which I am discussing right now. And their presentation is usually they're seen in the 5th or 6th decade of the life, and median age of presentation, as I mentioned, is 56 years, and they can present with some focal neurological deficits. They could present with some ocular symptoms like blurring of vision. And if you look at the biopsy we prefer is stereotactic needle biopsy, which is followed by the immunohistochemistry, and they typically express the B cell markers like CD19, CD20, CD22, CD79A, PAX5, and all these kind of markers. And they are basically a highly aggressive variant of DLBCL, diffuse large B-cell lymphoma, non-Hodgkin lymphoma, which often carries poor prognosis. So all these are the key features of the primary CNS lymphoma that you need to keep in mind. Thank you very much.